Okay, today our kind guest and audience, we will talk about a very important subject, which is the headache. Uh, we know that the most common presenting complaints to the neurologist in our clinic, in neurology practice, is the headache. And over 3 billions worldwide suffering from the headache. 1 billion of them, they are suffering from migraine. So a very important point that from our clinical practice as a neurologist, the point that when patients came to our clinic, they don't know what or which type of headache they have actually. And this is usually evaluated and managed by a specialist neurologist and neurologists that have interest in headache management. So our target today of the lecture is to make increase the awareness of the migraine, as a lot of patients, they don't know that they have a migraine or not, and they thought that the headache is just a headache. They don't know that their headache might be migraine, and this migraine, it needs to be treated, as the migraine, it affects on the quality of life of the patients in different way. It affects their quality of life, physical activity, social engagement, and psychological status. And we found that if we diagnose migraine properly and give the proper treatments of migraine, this it will affect on their quality of life. They can engage in the social activity, and they can do the daily routine activity. The second important point that I want to focus on it, that today our nice guest speaker, Dr. Sweta, she will discuss in detail regarding the new modality of treatment. The second important point, that a lot of migraine patients, after they diagnose, they don't know that we have a new era now of migraine management. That it's, we can say to some point that it's, I will not say curative, but it will prevent the migraine frequency. It will affect on severity and durations. So today also we will discuss the new modality or the new era of migraine treatment, which are by anti-CGRP treatments. Today our guest speaker, she is Dr. Sweta. She is a fellow of American College of Physicians from USA, and she is MBA certified from Cambridge, UK. She is a specialist neurologist and medical director in RAK Hospital, Ras Al Khaimah, UAE. Actually, her special interest is to take care of those patients that are suffering from headache and migraine. And she ran over the well-dedicated migraine clinic in her hospital to give them the specific diagnosis, specific treatments, give them the opportunity for the new modality of anti-CGRP treatments. She has over 40 scientific publications in the field, and she has also 2 chapters or 2 books chapters in neurology. So Dr. Sweta, she will explain in details today regarding whether your headache is migraine or not. And she will explain also the new modality of anti-CGRP treatments. Hopefully that this lecture, it will finally increase the awareness of migraine. And this is our goal today, is to make the migraine familiar to our audience, and how they should seek an advice if any of them suffering from what we will explain today in our lectures regarding the migraine. As the proper diagnosis and the proper treatment, it will significantly and dramatically impacts on their social life and daily activity. The webinar is actually it's open for Arabic and English audience, so they can put just their questions in the chat box on the screen. So hopefully at the end of the lecture we can answer these questions. There is a chat box. Just if anyone has any questions for Dr. Sweta or for me, we can help in this. There is a chat box, so you can put just your answer, and inshallah we will answer it in proper way. Dr. Sweta, how are you?
Yes, good evening all, and Dr. Mohammed Magid, very nice being with you on this webinar. Extremely eager to share. Thank you for moderating the session. Thank you.
You are welcome.
Thank you to all the participants for being here. Thank you, Novartis. Thank you, MCO. Indeed, it's a great pleasure talking about migraine because I have one and I exactly know what the patients go through. When you suffer from something, you actually know the pains of it. And that is the reason why I'm extremely... So headaches. Do you have one? Particularly, we are going to talk about, do you really have migraine? So whatever the headache that you are suffering from, is it really a migraine? This is a very fundamental question. Even before the start of the webinar, I am seeing a couple of questions posed that I have this type of headache. Can this be migraine? Is it different from temporal arteritis? So our job here is to give exactly the points which can give and help you in understanding whether your headache is indeed a migraine. So how do you know that you have migraine? And Marwa, I would like to share as I finish talking about this. So whenever you have one-sided headache, and often the sides can shift, so you can have a right and a left alternating one. Often you have a moderate to severe pain. It is often throbbing in characteristics. It is aggravated by doing the activity, often associated with nausea or vomiting, and light insensitivity or sound. Most of the times, the patient would like to just lie down still, close all the lights, and have something around the eyes so that the light is not bothersome. Now, if you, as a patient, have tick marked at least 3 or more of these boxes, very likely that your headache is a migraine. Now, again, you have to understand that not all headaches are migraines, and migraine does not behave like any other headache. We will talk about a lot of types of the headache, but this is very important and crucial to understand that do you have migraine? So Marwa, I would like you to translate this in Arabic, please.
Sure, Doc. بخصوص اللي شرحت الدكتورة سويتا عن كيفية التفرقة ما بين الصداع والشقيقة، فالشخص ممكن يميز عن طريق الأعراض اللي بيعاني منها. هل الآلام بيعاني منها باتجاه معين؟ هل هي باليمين الرأس أو اتجاه اليسار أو المقدمة أو مؤخرة الرأس؟ بالإضافة هل هو الشخص نفسه رح يعاني من بينزعج من الأضواء اللي حواليه، الصوت يفضل إنه يكون بمكان منعزل من غير أي صوت أو أي ضوء. كمان بتميز عن طريق الصداع مختلف عن آلام الشقيقة. كل هاي الأعراض بناء عليها الدكتور بتقيم هل هو آلام شقيقة أو هي آلام صداع عادية ممكن تيجي لأي شخص. ورح يكون في فرق كمان في الصداع. رح تشرح لكم إياها الدكتورة مع المؤتمر تكملته.
Thank you, Marwa. So this migraine indeed is really very common. Now, if we talk about the country that we live in, UAE, it's one of the commonest disease that you will find. So 1 out of 4 people would suffer from migraine. And if we talk about the world, as Dr. Magid was referring, 1 billion people are actually suffering from migraine, which is a very big number, essentially 1/7 of the world. So you are not alone. If you are having any of these symptoms, you are also one of these 4 people who can suffer from it. Now, it's not uncommon to have even younger children to suffer from migraine. A lot of people come into my clinic and say that, but my child is just 10 years old. He's just 12 years old. Well, it is not uncommon to have this type of headache in young childhood kids. And migraine is a genetic disease. 70% of the times we find one person in the family history, having a migraine headache. So if you really have somebody in your family, either the first degree, so your mother, father, brother, sister, suffering from a similar type of headache, very likely this is migraine. And most important is that you can have two types or two varieties of migraine, which is recurring type, which means in a month, the number of the times that you get the headache, if it is under 15, it's called episodic migraine. And if it is more than 15, it's called chronic migraine. We also have to understand, and Marwa, I want you to translate this last part, that more number of women suffer from migraine than compared to women. So 3 times more that women is more likely to have the migrainous headache. Marwa.
بالإضافة دكتور بتوضح أنه نسبة بليون شخص بيعاني من مشاكل الشقيقة، وأيضا هو مرض أو فينا نحكي يعتبر وراثي نوعا ما، لازم يوجد شخص بالعائلة بيعاني من هالمشكلة فبتتوارثه الأجيال بعد هيك. بالإضافة أنه النساء هن 3 أضعاف أكثر من الذكور بإصابتهم بمشكلة الشقيقة، فالنساء هم أكثر عرضة لمشاكل الشقيقة.
Yes. What is migraine now? We'll just go very superficially, because unless we understand that it is a special disease, it is something which is causing in the brain to have the pacemaker fired, we will never understand how best to treat it. So again, we go back to the fundamentals that we don't treat it like any other headache. So you can't just pop in a Panadol, you can't just pop in an aspirin. There is a way how we can treat it, as Dr. again Magid was referring, that there is a way, if not cure, but to prophylactically to stop the migraines from happening or the control. Unless we understand the basics of it, that's going to be difficult. So it's like it's an electrochemical storm. What is happening inside the brain is causing a lot of changes in the brain, which is responsible for this sort of the phenomenon that the patient with migraine undergoes. Now, there are 4 phases. So before the real headache, there is something called the prodromal phase, which means you feel tired, you have some sort of repetitive food cravings, you can feel very fatigued, you can feel yawning. This is like a prodrome, like essentially, let's say there is a thunderstorm. It's like just the lightning before the real thunderstorm. And then the thunderstorm hits in, which is like the headache, as we described, often unilateral, aggravated by physical activity. There can be very soreness, what we call as allodynia. The words are not important, but what can happen is there could be soreness around the scalp, which is very, very annoying. And once you can't comb your hair, etc., all, it can happen. The headache can last anywhere from 4 to 72 hours. And if it goes beyond 72 hours, generally it is called status, and that means you have to go to the hospital to treat it. But by and large, within the first 72 hours, it should stop. Now, post-drome, which means after the headache, again, there could be very severe tiredness, there could be some lightheadedness, dizziness. And yes, by the way, this is without the aura. Now, if you have something called aura, which means even before the headache sets in, you start getting some sort of symptoms. Now, this is very important to understand, because a lot of people get scared. So for example, I get a lot of patients who were driving and suddenly they can't see. There is some flickering of lights going around. There is some zigzag patterns that they are seeing, some geometrical shapes. Now, you don't need to worry about it if you are young. If this happens or one-off, immediately 20 to 30 minutes followed by a headache, very likely this is a symptom of aura. So Marwa, I want you to explain this phenomenon of aura, please.
بخصوص الأورا هي عبارة عن ومضات ضوئية أو طيف ضوئي يحدث قبل الشقيقة أو قبل آلام الصداع، مثل نجوم مضيئة أو مثل أحرف تحس فيها ضوء. فبالعادة بعض الأشخاص بيعانوا منها، فبناء على هاي بيكون بعد هاي الومضات تأتي أعراض الشقيقة في بعض الأشخاص.
Thank you. So these are some of the paintings which are there. In fact, London Museum has a significant collection of the paintings which are drawn by the people when what they see in the aura. Now, this can be quite disturbing, quite distressing. Obviously, anybody would get scared. However, it should go away within the 30 to 45 minutes period, and then the headache sets in. If it does not go away, which means it is not coming from the migraine, and you need to go to the doctor and get it assessed. But this is important to understand that this is one of the symptoms for people people who suffer from migraine with aura, and there is another type of people who are migraine without aura. So these are the two common types. Now, what are the common triggers of migraine? Now, this is again very important to understand. As I said, headache, any normal headache would behave a little differently from migraine, and food has a very significant role to play. Stress has an important, stress acts as an important aggravating factor. Dehydration can be one of the factors, and any sort of perfume, smell. Some people has a very significant this for foods like chocolate, cheese, particularly red wine. These are the common things which can aggravate migraine. This is important, and each person can have unique things. So you have to figure it out for yourself. What is the factor which is aggravating? For example, for me, definitely it is cheese. So I avoid all the foods that is causing me the aggravation of my attack. So you have to figure out and stop doing that. Marwa, I want you to talk a little bit about these aggravating factors and how they can avoid it in Arabic.
في بعض الأشخاص في بعض المأكولات أو بعض الأشياء المعينة ممكن تزيد عندهم نوبات الصداع، فكل شخص عن ثاني بيختلف. في بعض الأشخاص ممكن يزيد عندهم نسبة الصداع من أكل الشوكولاتة، بعض الأشخاص من الجبنة، بعضهم من النبيذ الأبيض، وبعضهم من العطور. فالشخص هو الطبيب نفسه لما يشوف إنه رح ينزعج من أو الصداع عنده بيزيد من تناوله للشوكولاتة أو الجبنة، لازم يتجنبها مثل ما تجنب الدكتوراه تناول الجبنة لأنه بيزيد عندها نسبة الصداع. وكمان نسبة المي لما تكون قليلة في بعض الأشخاص كمان بتزيد عندهم نسبة الصداع. لازم نكون إحنا مهتمين. الغذاء كمان مسؤول عن زيادة نسبة الصداع عند الشخص.
It's a bad news for those people who like chocolates. Unfortunately, chocolate aggravates it. For all those who are liking chocolates with migraine, I'm sorry for that, but that's one of the very important aggravating factors. A lot of coffee is also one of the aggravating factors. So caffeine also causes dehydration and it can aggravate migraines. Now, it is very important to understand how does it differ from other types of common types of headache. The commonest that we see in our clinic is tension headache. Tension headache is not the stress or what you feel tensed about. It's essentially like a band. It's like tightening of the muscles around your skull and scalp, which is the reason for your headache. Now, this is a constant headache. It's like squeezing headache. It does not have any other factors that we just discussed. So it does not have an aura. It does not have any postdrome. It is not associated with light intolerance. It is purely around the head, and it generally comes out in the evening. So it starts in the late evening and gets to progress as the day progresses. So this is important. Now, cluster is a one very unique type of headache, which very few people do get it. I do have one patient right now admitted with cluster. It's a very severe unilateral eye around the eye. It's kind of a stabbing pain, very, very excruciating. And this is often not commonly seen, so we'll not talk much, but it's important to remember that if you suffer from repeatedly in a rhythmic fashion, so every January, for example, you have this type of headache, or every June you have this type of headache in a calendar fashion, you have to go to your doctor and get it examined. It could be cluster. And now all the newer therapies can be offered as well for cluster. So it's important to identify. Sinus headaches are common because a lot of people come and say we have dubenphia. So is it that we have the sinus? Now, sinus can be presented in multiple ways, particularly if you're looking down and your headache is getting aggravated. It's often likely that it's sinus. It's often in the area which is drawn on the screen. It is important that tension headache is understood well. So Marwa, I want you to translate essentially tension headache, please, for people. It's like a band and it can be squeezing in characteristics without other features of migraine.
بخصوص كمان الصداع هي أو الشقيقة، حابة توضح إنه مو كل الأشخاص بيعانوا من ومضات أو طيف ضوئي. في بعض الأشخاص اللي هي مثل ما قالت كيف نميز نحن هاي الآلام تابعة من الجيوب الأنفية مثل ما قالت، أو إنها الصداع تابع من مشاكل شقيقة. بيكون مثل رباط شيء بضغط على حوالين الرأس، بيكون سبب الصداع التوتري، وهو بيكون مثل شريط دائري أو شيء مثل حزام حوالين الرأس وبيضغط على الرأس. فيفضل إنه دائما في هاي الأعراض إنه دائما تابع دكتورك الأعصاب لا يخبرك العلاج المناسب.
Yes. Now, what important other thing to remember is also when does the migraine set in? So it can be from in the productive years, so all the way from 26, 27 until the age of 45, 50. So it's a very wide group, wide range of age when you can get the migraine, while tension can happen at any age. So it's also important to remember that migraine is very common in these most productive years. We often see patients who are working in the banks, who are working with the systems, IT professionals, computer experts, who because of the constant exposure to screens, and today because of the pandemic with all these digital exposure, also has aggravation of attacks of migraine. So very important to differentiate between the two, tension and migraine. If you do have nausea, vomiting, light intolerance, sound intolerance, side. Now, remember again, persistent side locking, which means continuously getting the pain on one side, is unusual with migraine, and you have to go to your doctor and get your scans done. So it is important to understand what type of the headache can be migraine. And that is essentially the reason why we are here talking about migraine. It is also important to monitor the headache. Now, often in my clinic, I see a lot of patients who get these weekend headaches. So all the week you're working, and then suddenly comes a Friday when the headache begins. It's called a snap headache or zap headache. So it's very important to know what is triggering, when does it trigger. For example, in women, it can be related to menstrual cycle. So if you have actually drawn down a map of your headaches, it can help your doctor figure out what could be the potential reason and how best it can be treated. Now, there are umpteen apps which are available online. So we at RAK Hospital have followed a one particular app called Headache Journal, and we give it to all our patients, and we dedicatedly follow their diaries so that we know pattern, what is happening, etc. But you can just pick up anything, your iPhone, Android, and start noting it down in the calendar. This is the first step if you have migraine. And very sincere request to all those who have been listening in the seminar. Marwa, I want you to stress on what is the headache calendar like.
بخصوص جدول الصداع، نعطي لكل مريض عم بيعاني من الصداع لتميز الدكتورة شو هو الصداع اللي بيعاني منه وكيفية تقييمه بهي الطريقة. بيكون هل الصداع الفترات الزمنية اللي أتى فيها، الشدة هل من 1 إلى 10، الأدوية اللي أخذها، قد كمية الحبوب اللي تناولها، كم مرة بالشهر، الصبح أو مساء، الفترة الزمنية، كلها بتكون مفصلة بطريق هذا الجدول الزمني. فكل متابعة المريض لعند الدكتورة بيكون الجدول معه، فبناء عليه الدكتور بتقدر تقيم قد ايه مرة اجت له النوبة الصداع في هاي الفترة الزمنية اللي كان غايب فيها عن الدكتور، وقد ايه كمية الأدوية اللي تناولها، وكيفية حدوثها، وكمان بكتب كل التفاصيل الموجودة عن طريق خانات.
Yes, thank you. We discussed about this. What is actually a migraine? Now, migraine is essentially a disease. So what happens in the brain is there is a pacemaker. It's called trigeminal ganglion. I'll show the picture a little later. What we need to remember is there is a electrochemical disturbance happening, and release of all the chemicals which are essentially causing the pain in and around the blood vessels, in and around the brain, which is the reason for the headache. And what it is doing is it is constantly being triggered by certain episodes, and that's why it can happen in an episodic fashion. It can happen with aura, without aura. We discussed this. So I want you to understand, and I'm going to show that picture. I'm just going to go one slide over it and come back to this. Yeah, this is the picture. So essentially what is happening is inside the trigeminal ganglion, you are essentially causing the cascade of stuff which is happening, releasing the chemicals. Now, one of the nasty one, which is responsible for it, is called CGRP, and we will talk about that in our treatment. Marwa, I want you to focus on the pacemaker phenomena in the brain causing the migraine, please. Marwa? You're mute, sorry.
Yes, Saidam. هلا الصورة الموضحة أمامنا عن التيار الكيميائي اللي بيمرق في داخل الدماغ، اللي هو بيكون سببه أو الطريقة اللي ببلش فيها الصداع في داخل الدماغ، بيمر بالمنطقة اللي هي موضحة أمامكم بداخل الصورة، عن طريق الأوردة اللي بداخل الدماغ، فبالتالي هاي هي المسار اللي ببلش فيها الصداع.
Yes, thank you. Now, do we need to do scans in migraine? Now, this is a very important question because a lot of people come to our clinics. I'm sure Dr. Magid would also have that experience that I have varum in my brain, possibly. That is the reason why you need to do the scan. Now, obviously, anytime when you get the headache, it can be scary and it can be that you have tumors, etc. But if you have any of the symptoms that we just talked about and it's a pure migraine, MRI scan is not necessary. However, the doctor can actually talk about your history, rule out all the other factors which could be the reason for headache. And if he or she is convinced, then it can be a clinical diagnosis. So this is what I often hear, that let's do the MRI. And anyways, if you do the MRI, there's no harm in it. It's a magnet. And if you do find these white spots, what you are seeing on the screen, these are called UBOs, or unidentified bright objects. Now, I think the radiologists like to use some fancy terms as though we're talking about some aliens, but it is not some alienated language. It is just these white spots. What you can see in migraine, and nothing to worry about it. There's no cause or reason or concern about the same, and you should not be stressed about it. Marwa, I want you to talk about when do you need an MRI, and should you be so worried if you find anything?
بخصوص السؤال المتكرر لكل المرضى، أي مريض بيعاني من صداع أو آلام بالرأس، أول سؤال بيستفسر منه: هل أنا بعاني من ورم بالرأس؟ هل بيلزمني أن أشعة رنين مغناطيسي؟ بناء على الأعراض اللي حكيناها سابقا، إذا كنت تعاني من أي عرض من العوارض اللي ذكرناها من قبل، فعلى الأغلب ما رح يلزم إنه تعمل أي أشعة. بس إذا كان المريض يحس بالاطمئنان لو عمل أشعة مثل ما حكت الدكتورة، هي أشعة مغناطيسية، فبالتالي هي آمنة. وبخصوص النقاط الموجودة في حال الأشعة، بل فيها نقط، بنستعمل مصطلح بسيط انه هي نقط بيضاء داخل الراس، بالعاده ما بتشكل مش مرض او اي شيء ممكن خطر او بيشغل البال، فهذا الشيء امن وما في اي شيء بداخل الدماغ.
Yes, thank you. Now, since somebody asked the question, is it temporal arteritis? Now, you also have to understand temporal arteritis is nothing but the artery which is going on the side here, and it is inflamed, iltihab. And because of this, you sort of get a continuous pain. Some blood tests helps the doctor in identifying such things. For example, a high ESR, if you have a very high ESR, only one-sided, as I discussed, that if you don't have other features, you don't have nausea, vomiting, light intolerance, sound, it is not a migraine, then obviously the doctor will hunt for other causes. So as a part of that, you can get your blood chemistry drawn, you can do the MRI as I just discussed. However, it is important to identify and classify. Now, I see a lot of patients in my clinic who do not have a diagnosis of migraine. And 40% roughly, this is what the trials say. There are very big trials, including 20,000, 30,000 patients by American Headache Society, where 44% of the people don't actually have a diagnosis of migraine. And this can be hurting because you are berefting yourself from all the fantastic agents that we have right now. I often tell that as colleagues, I'm sure Dr. Magid will agree that this is the best time to practice migraine because we have pretty much everything which is state of the art, the best sort of therapies targeted at the real problem. Now, initially, we used to take a lot of medications. We will discuss that in the management, the second half. I saw one question about beta blockers, so park it for the second half of the thing. It is very important that we understand that the doctor will definitely take the history, figure out what your headache is, but it's important that you go to the right person. So now, who can be the right person? Now, most of the times, yes, a couple of headaches, GP, physician, internal medicine, everything is fine. Sometimes you do have a lot of anxiety about the headache. You might land up with a psychiatrist. But the real important player, so to speak, to take care of your migraine is often always a neurologist, because the neurologist essentially knows in and out of migraine. Although migraine is such a common thing that every single doctor on this planet Earth, I bet, swear and say that would have seen the patients of migraine. It is such a common disease. So again, we are not alone in this game and fight against the migraine. I told you initially also, I am one of those. I am also the one who suffers from episodic migraine. So Marwa, I want you to tell them that yes, once they talk to the neurologist, once we get the history sorted, we can give the label or the correct diagnosis, which is important and which is often missing even at the level of the world. And we are fortunate that we have the access of specialist neurologists and other such specialists who can diagnose rightly the migraine with the right label. Very important.
الأهم مثل ما قالت الدكتورة إنه تتابع مع دكتورة كل الأعصاب ليقيم الصداع أو الشقيقة بطريقة صحيحة، لأنه الشقيقة شائع في يومنا هذا، كثير أشخاص بيعاني منه. فبطريقة تقييم الدكتورة بالأعراض اللي بتعاني منها فأكيد رح تلاقي الحل والعلاج المناسب وكيفية إنك تستمر بكيفية أخذ العلاج وطريقتها ومع دكتورة الأعصاب.
Yes, thank you.
Sweta, we have 5 minutes to
yes,
shift for the another.
Just the last slide, yes. So this is what we were talking about, the pathophysiology. And in the pathophysiology, what I just showed was the ganglion, the trigeminal ganglion. And what you are seeing there is essentially the structure where the CGRP, the bad guy, let's call it the bad guy goes and attaches on the receptor when this whole cascade starts. So what we have to deal with is essentially this thing when we are talking about the treatment of migraine, which is going to be our next talk. Now, also to understand that as you are noting the calendar, I want you to also note that you should not be overusing any of the medications. So if this is your headache and you start taking the medications here, the headache would go up here and again up here. So it's like a cycle. So there is also something called medication overuse headache, which has to be avoided. So this is again important. I see a lot of patients who just park their tablets here and there, you know, in the closet, in the car, in the laundry. This is a wrong practice because then you lose count of how many medications you are taking and you are inviting the headache. So this is going to be my last slide. So Marwa, please talk about the medication overuse headache.
الأهم من هذا عدم الاستعمال المفرط للأدوية. لو كان بيفرض إنه في عنا مستوى للصداع، نحن أخذنا أدوية لنسكر الصداع اللي عنا، بعد فترة الصداع شد علينا فنحن رح نزيد استعمال الأدوية أو كمية الأدوية لنخفف الألم، فبالتالي بيشد الصداع أكثر. فبتلاقي حالة بحلقة مفرغة إحنا باستعمال المفرط للأدوية، وبتلاقي الأدوية بالسيارة، الأدوية موجودة بالبيت، الأدوية بكل مكان، وبنستعمل بطريقة عشوائية لكمية الحبوب، فهذا يعتبر استعمال مفرط أو خاطئ للمسكنات.
Yes, thank you. And then from here on, we will be moving on to the next session. So I finish my part 1. Thank you, Dr. Magid, and thank you, everybody. Sure, thank you. So welcome again, all of you. I thank Novartis, Dr. Magid, the MCO, for having this wonderful evening where we are in this era of migraine management. I think I told again, I will stress again that this is a very important era for us as clinicians to be of help to you for the patients, because there cannot be any phenomenal discoveries in migraine. And mind well, we know migraine for last 7,000 years and beyond. So it's not that migraine is new to us, but all these medications are making a big change in our lives. So we will be talking about, and most of your questions, which is centered around how best to treat the migraine, what we can do, etc., can be answered in this session. So thank you again. Now, can migraine damage the brain? Well, the question is, it is a neuroinflammatory process. It can be disabling to have the headache, but it's not killing any neurons. So it's not degenerative in a way. It's not damaging the brain. But of course, with all the electrochemical processes that I just described, it's not pleasant to have either. So our goal is to treat as many attacks as possible appropriately and to have something so that you don't get the attacks. It's very important to control them. Unfortunately, we don't have a cure for migraine, but control definitely exists. And that is what is the highlight for us when we talk about migraine. If we are monitoring it well, if we know exactly the trigger factors, then we can also know the lifestyle changes. So we will talk about some of the lifestyle changes as well as some real rationale with the agents. And I'll share some of my clinical experience, what we do with our patients. Now, of course, it is not easy to live your life with migraine. If we look at the quality of life questionnaires, so we give to our patients some sort of questionnaires talking about how much is it impacting their daily life, how much of the time that social impact is there by the migraine, how much of the time you cannot take care of your family and all, and it can be sometimes significantly high. We use a simple tool called Maida Score. You, as a patient, has to fill it out, and if it is more than 21, indicates that you are suffering from really disabling type of migraine, and that is where you need to come and seek help for the migraine. Marwa, I want you to talk about that two aspects. So we'll talk about lifestyle as well as the management in this particular session in Arabic, please, for all our Arabic viewers.
رح تتكلم الدكتورة عن كيفية نحن العلاج، إنه مو من السهل إنه متواصل حياتك وعملك وأنت بتعاني من صداع، أو أنا حتتأخر من حياتك الاجتماعية، حياتك العملية، كله رح يتأخر. فبيكون في عنا نحن مستويات للصداع. رح تخبرنا الدكتورة عن كيفية العلاجات وكيفية الطرق والسبل اللي ممكن إنك تطلع من حلقة الصداع لتكمل حياتك الطبيعية.
Yes. Thank you. And we just said that it's no other migraine. So how we treat any other simple headache, for example, the headache that you went out because you were exposed to sun, or simple tension headache, or you could just pop a Panadol and it gets over, that is not migraine. So migraine is a disease properly, which has to be treated appropriately with care. Now, as I said, 7,000 years back, we know migraine. You know, there used to be time when people used to drill literally the skull, holes into the skull, you know, to treat migraine. And it was called trepanation. You can see that it was a very, very, very disabling type of the things, because people didn't know what really to be done. But now we have proper therapies, and I would be talking about 2 or 3 things. One of the agents that I'll be stressing on is an injectable new therapy, which we have. It's not so much new. It's about a couple of years that we have now. It's every monthly, an injection to prevent the migraines from happening. And some of the medications which are used during the attack, because we only know the Panadols and the diclofenacs and the NSAIDs, what we call the non-steroidal anti-inflammatory agents, but we really have to understand what can work beyond these medications as well. So since I just said this is the slide for people in Arabic. And the medication that we will be talking about is the Ntcgrp. But before going to medications, I think any doctor who really is a healer would say that try to avoid medications as far as possible. And that is also the story with migraine. We talked that if you start consuming more and more of the painkillers, you're not actually helping, you're harming the process of migraine. So that is the reason why lifestyle is a very important thing to be done if you suffer from migraine. Getting enough sleep, 8 to 10 hours, is essential. In fact, 8 to 10, I'm over quoting it. Even if you get 6 to 8, I see a lot of patients who come, they say we sleep by 1 or 2 o'clock and then go back to work by 6 or 7. Now, this is not helping in the migraine at all. Every day, consistent exercise is very important. Now, exercise is actually serving you in many ways. It is producing something called BDNF, or the brain-derived nutrition factor, with neurotropic factor. It is actually causing your neurons to be happy, to be healthy. You're getting all the right chemicals. And in fact, exercise is also producing the chemicals which can attack the pain. So exercise is an important part. Eating the right type of the food, avoiding the bad type of the foods, and definitely stress. Now, a lot of patients come to me and say that I think the reason is the stress. I am stressed, and that is the reason why I get the migraine. Well, migraine was always there, but the stress triggered the phenomena. As we just discussed, migraine is a genetic disease. You often get the gene so that the whole disturbance in the pacemaker happens, and your stress is only adding fuel to the fire. Marwa, just very quickly, these 3 or 4 points about the lifestyle.
الأهم من كيف إنه نحن نساعد نوبات الصداع ما تكون أكثر، هي أن نأخذ وقت كافي للنوم، ما ننام وقت متأخر أو ساعات قليلة، بالإضافة للتمارين. التمرين مش فقط بيساعد الصداع، بالحياة بشكل عام لنفسية الشخص. التمارين كتير شيء مهم، بالإضافة للطعام، الأكل الصحي. نتجنب الأكل ممكن يزيد من نوبات الصداع عنا، والضغوطات أو التوتر كمان، هالأشياء بتزيد من نوبات وشدة الصداع.
Yes. Now, how do you treat migraine? So there are two components of treatment of migraine. One is the headache itself, and second is the prevention of the headache from coming in. Okay. Now, when you have the headache, what you need to do is something called as abortive treatment, which means you want to abort, you want to stop the headache from happening or from lengthening or prolonging. So that is when you use one of the medications. While prevention, which means you don't want those attacks to frequently come. We just discussed that they are going to come. There's going to be a pattern of headaches because every time there's a trigger, it's going to start the whole process. It's like a little factory, right? You just kick in one thing and it will sort of churn itself and get the headache out every single X time, which is why we call it as an episodic migraine or chronic if continuously it is happening. So what we need to do is please understand these two important facets of treatment of migraine. So what do you use for acute treatment? You can use any of the painkillers, naproxens, your brufens, or your diclofenacs, but also understand that there is a group of agents called triptans, and there is also one very new agent called lasmiditan or Riva. Now, the triptans are actually the agents which are helping us in exactly treating the real reason where the pain signals are happening. So it is directly working at the pain signals. So you can't pop in a triptan if you have an elbow pain or a knee pain. No, you can still pop in your diclofenac if you have elbow pain or a knee pain. So triptans are very specific. So let me give some of the random names. I'm sure some people who are here would have heard them. Sumatriptan, Zolmitriptan. These are some of the common agents which are available. For us here, you start with a certain agent. You can only repeat that after 2 hours. If no relief, you can repeat it in 24 hours. And the painkillers or other NSAIDs, that is when you can take in during the headache. Now, most of these agents, the triptans that I talked to you about, cannot be taken if you have certain disease. So for example, you're suffering from heart problem, you're suffering from any of vascular problems, then these are not the agents for you. When the third agent called lasmiditan comes to your rescue, and there are some certain things that you don't do when you are taking lasmiditan, like driving, etc. and all. But again, the important point to stress here is that you cannot mix that because you are taking these agents, that's why you're treating your migraine. In fact, you're not treating your migraine, you're only treating your headache. So if you want to treat your headache, use either of these agents. But while it's always better to try out triptans, roughly about 70 to 80% of the people do respond to triptans, and they also can prolong the duration between the attack to attack. So it's important that you understand this facet, while also to understand that you want to stop the attacks from coming. That is when all your beta blocker, so Inderal, I think that's what the question was, your beta blocker. Now, these were all the old time agents which we were using. We still use it in certain cases. Amitriptyline, I'm sure a lot of you would be familiar with Depakin. These are all the agents which are used for one or other indication. For example, amitriptyline is also used as an antidepressant. Your Depakin is also used for people with epilepsy. Beta blocker is used for people to slow down the heart rate. Now, we use this so that the prevention of migraine happens. So I hope this is very clear to understand for you as patients that why we do what we do. Marwa, I want you to stress on this preventive and acute treatment, please. I think you're mute, Marwa.
Yeah, it's fine now, doc. هي حابة توضح الدكتورة لما يبلش عنا نوبات الصداع، في منها بعض الأشخاص بياخذوا فيه مسكنات لها مسميات كثيرة، عندنا نبركسين وعندنا في مسميات كثيرة، في بعض الأدوية مثل ما قالت تريبتيتان، بس مش لكل الأشخاص ممكن ياخذها. الأشخاص اللي عندهم مشاكل قلب أو أوعية يفضل إنهم يتجنبوا هاي الأدوية. بالإضافة في بعض الأدوية مثل ما قالت بزمان بيستعملوها لبعض الحالات، لهلا ممكن يستعملوها في بعض الأدوية لعلاج مشاكل الاكتئاب، الجرعات العالية منها، بس الجرعات القليلة تنعطى كمان لمشاكل أو نوبات الصداع بالشقيقة سوري. بالإضافة في أدوية تستعمل أشخاص اللي عندهم مشاكل صرع، بس هاي الجرعات العالية، كمان الجرعات القليلة لبعض الحالات مش لكل الحالات. وبعض الأدوية أيضاً اللي عندهم سرعة في دقات القلب تنعطى لأشخاص معينين بيعانوا من نكسات أو نوبات الشقيقة.
Yes. Now, do you need to take any of these medications that we just discussed, which will prevent it? That is a good table here, which you can see. So if you have just 2 or 3 headaches in a month, everything is counted on a monthly migraine headache days, then you don't need it. But yes, if they are severe enough, it is hampering your quality of life. If each attack is lasting for 3 to 4 days, then indeed you are spending about 8 or 9 headache days with 2 or 3 attacks, then definitely you need to consider. Of course, if you have more than 6 or more than 10, you are definitely having a big impact in the quality of your life, and you should be starting on one of these agents. Now, generally, our practice as clinicians is to give it for 6 months, up to 8 months or a 12 months, and then stop it. Then you have a longer remission period, which means the migraines don't come in. This is a general practice, but again, it is very individualized. So you as a patient has to give your proper story for the doctor to understand whether that is right for you or not. There are a lot of comorbidities, which means very simply that you can have multiple things together. So if you have high blood pressure, we would be glad to use beta blocker. If you have a problem with your migraine, depression and migraine, we would be happy using antidepressants. Now, again, but to stress the point that these were all old-time agents in the era when we have understood migraine pathophysiology. The Ntcgrp is the key molecule to be understood here, and we should spend the rest of the discussion talking about it because it's very important. And these are the new cutting-edge agents which are available with us. We are talking of a simple thing, like I'm sure most of you would have seen something like an insulin pen. It's like a self-injected pen that you give. Most of these agents are also available in a monthly injection format. You can do it yourself, or you can come into the clinic and get it done. Now, if you are suffering from this week-long migraines, if you have been using a lot of painkillers, you've already tried any of these agents that we just talked about, then essentially these are the new age therapies which are for you as a patient. Marwa, I want you to translate this.
بخصوص العلاج مثل ما خبرت الدكتورة، كيف نقدر نحن نقيم الأدوية المناسبة للشخص نفسه من تاريخه؟ لازم يخبرنا تفاصيل الحياة المرضية عنده، فهي بتعطيه الأدوية الصحيحة. هلا بالشيء الجديد الصادر هو عن طريق علاج إبرة، هي إبرة بتتاخذ مرة كل شهر، كتير عملية وكتير سلسة، مثل القلم، تنعطى مثل كيف إبرة مرضى السكري بالإنسولين بطريقة كتير هينة. قد الفترة الزمنية اللي ممكن يستعملها المريض تختلف من شخص للآخر. إذا هو آيس من كل الأدوية، استعمل كمية كبيرة من الحبوب والأدوية، ما جابت أي نتيجة، الصداع على ما زال بشد أو نسبته قوية، فهو الأفضل له الإبر المتاحة لها فترة تقريبا كم من سنة هي متاحة حاليا وكثير مرضى استعملوها.
Yes, so now you're just seeing right in the second half, the pen that is like a simple pen, which you can just inject it. It's available as 70 milligrams. Now you as a patient, I think it's again, as I said, it's very fortunate. I also as a patient that we have this therapy every monthly. Once you start taking this, you start monitoring your headaches and your headache frequency. And we as clinicians are interested to see if it's dropping more than 50%, more than 75% every month on month. Now this will be a great win. So anybody who is suffering from, let's say 10 migraine headache days a month, and after starting the therapy, it becomes just 4 or 5. That's a phenomenal change in the quality of life, which is what we are looking at by offering these sort of agents. Now, anytime any doctor, as I said, is not interested in the medications unless it's safe, unless there are no untoward reactions, unless it's not causing any other interactions with your other agents, etc. And this is one of the fantastic points about these Ntcgrp agents, that they are completely safe to take. Now, I think I have roughly about 50 patients on, exactly to be specific, I think I have 46 patients on Aimovig or Erenumab. Most of them have done very well. We generally start, if you have failed one of these agents, you can start also if you are a completely new naive migraine, only injection site pain or a little bit of reactions. I think we'll hear from Dr. Magid also his experience. Other than that, and a little bit of constipation, we haven't had any major serious adverse events with these medications. None of them have even died, or none of the serious adverse effects has been seen in the clinical trials. Now, we have very robust scientific literature which is backing up these therapies and enough to suggest that this is the way to go for future. So I think all the other stuff that we talked about, because it is borrowed to be used in migraine, I borrowed it from epilepsy, I borrowed it from a certain heart problem, and I'm offering for migraine, that is stop. This is like a personalized tailor-made coat, for example, which is only fitting me. So these are the agents which are just fitting the problem with migraine. Marwa, I want you to talk about the injection pen a little bit more so that it gets the message through.
لتوضح بخصوص الإبر المتاحة حاليا لمشاكل الشقيقة، قبل كنا نستعمل الأدوية مثل ما خبرتكم في بعض الأحيان الجرعة العالية منها لمشاكل الاكتئاب، الجرعة القليلة لمشاكل الصداع. لا، هاي هي مختصة فقط لمشاكل الشقيقة. هي إبرة بطريقة كثير سلسة وسريعة بياخذها المريض مرة في الشهر. هلا بقيم بعد هيك الشخص اللي بيعاني 10 نوبات بالشهر من مشاكل شقيقة، وبعد استعمال الإبرة صار اختلاف من 10 نوبات شقيقة ل5. فهذا اختلاف كثير واضح وكثير جميل بخصوص الفرق بالعلاج. وفي مسميات، في لهم في شركات، في عندك الاموفيل كمان مش مختصة فقط للشقيقة، وأيضا الريافيل كمان للشقيقة فقط. فمضاعفاتها أو الآثار الجانبية لها الأدوية كثير قليلة، فبالتالي المنفعة منها واضحة لكثير أشخاص. تقريبا مرضى اللي عنا بمشفى راك صاروا 46 مريض عم بيتابعوا معنا العلاج الشقيقة عن طريق هاي الإبر.
Yes, thank you. The doctor can tailor the dose. It's available as 70, 140. So you just speak to your doctor and understand the type of the dose that you will need, whether you are eligible or not. All that would be by a discussion. The other thing which is very helpful in my personal practice is also cephali or kephali, however you want to call it. It's like a little band which you use it, and it's for acute headache as well as it is for chronic use, daily add-on use. I often combine 2-3 things. And it is often always the correct sort of it's like fine tuning. So you can just get the frequencies, but once you fine tune based on your sort of the type of the headache, I think it just works very well. Most of the patients, if they understand all these factors combined together, take the right type of triptan, for example, for the acute pain, have been put on the correct Ntcgrps, they use all the lifestyle factors. Believe me, migraine is extremely easy to be dealt with, but if we just don't do things right, it can be a disaster. So this is very important to understand, and this is what we are talking about, that painkillers are not the solution. I don't know, I think I want to hear from you, Dr. Magid, how many patients do come and say that, but yeah, I have been taking Panadols, I have been taking Panadol migraines, I have been taking these, and I have been dealing with my migraine. Well, again, to stress that you're just dealing with your headache, and which is very different from dealing with a migraine. And we have to utilize these agents which are directly acting at the real pacemaker, which is the challenge in migraine, and start using appropriate therapies. The goals for us as clinicians are very simple. The goal is that you don't get a headache. Even if you get one, it is mild. You can just go with your daily life about it. You get some medication which is safe. You get a quick recovery. Your headache attacks are prolonged. We cannot eliminate your headaches, but we can make you as comfortable as possible. And if we look at your diaries, now sometimes it's very, very, very reassuring once we look at the patient diaries and you have gone from all the way from 15 to 5, which is what we want. So this is again very important for us to help you in your migraines. Marwa, I want you to talk about all the factors combined to help treat the patient, not just one factor in isolation, but it is doing the right steps at each point in time, right from the diagnosis until the treatment.
هلا مثل ما حكت الدكتورة، مش فقط الهدف اللي نحن بدنا نوصل له نقلل عدد النكسات او النوبات اللي بيعاني منها الشخص، ولما تيجي نوبة الصداع تكون خفيفة، عن طريق نحن لازم نعمل الاشياء المناسبة للشخص، نتجنب الاشياء ممكن تضر او الاشياء اللي ممكن تزيد نسبة الصداع عنا، ونشوف العلاج المناسب في الطريقة المناسبة الموجودة او العلاج المناسب، لأن الدكتور هو بيقيم قد ايه الجرعة لازم ياخذها الشخص، بالإضافة الأدوية اللي بتستعملها كميتها، ولو في حال إجا الصداع تكون شيء كتير بسيط تكمل حياتك اليومية من دون أي معوقات ممكن إنها تقيد حياتك، فبتقدر تستمر بحياتك اليومية. وهذا هو الهدف إنك تعمل الرابط بين الأشياء اللي بتناسب الشخص عن طريق اللي عرضته الدكتورة اليوم، وأنت بتقيم شو هو الأصح من طريق سجلك مع الطبيب.
Yes, so this is my last slide, that most of the patients would be actually, as clinicians, we said we want you to reduce 50% or more, and we also want you to go less to the emergency rooms to get your IBRAs or to get your injections. We don't want that, and essentially that is the reason why each of these therapies is very important. Now, in our facility, we see roughly about, let's say, 6,000 odd neurology patients each year, out of which 2,000, 1/3 of patients have headache. And about 1/3 of that, which is about 700 patients roughly annually, are suffering from migraines. And if we really properly curate it and see who all can be beneficial, again, roughly half of the people have a typical disabling type of migraine, which needs help with one of these Ntcgrp therapies. So Aimovig injection, I've been extremely passionate in using it, and I have in my practice. Most of my patients have done very well. A couple of them, in fact, are also stopping the injection after a certain time. So we have had people who stopped 6 months, after 9 months, and even over a period of a year following that, their headaches have been in control. So this is essentially the importance of treating it again the right way and in an appropriate manner. So I think we have a lot of questions, and we should keep some time for the discussion. So thank you again for inviting me, and it's a pleasure talking to you. And I would be glad, more than glad, in fact, to answer any particular questions about your headache, because each headache is unique. Yes, we can talk about migraines, but if you have a particular question, me and Dr. Magid are more than happy to help. Thank you.
Thank you very much, Dr. Sweta, for this very nice presentations, precious informations, beneficial informations that you give to the audience. I hope that the awareness of migraine now, after this very nice presentations, it become more from Dr. Sweta. So I will go directly to the, as we have a lot of questions. So I will choose actually the questions from the list, which goes with our lecture. So I like one of the questions actually from the audience, Dr. Sweta. He mentions that what is the point of the treatments, or the treatments should be focused on which point? And this is actually focused on the second part of your presentations, that really treatment should focus on which points. So what we need to tell the patients, what is our goal, what is our targets in the treatments of the migraine in this new era?
So yes, the treatment in this new era is that your migraines can be prevented. You can actually stop your attacks from coming. You don't have to suffer the way you have been suffering. Otherwise, let's say you have been getting 4 attacks a month. This is a common thing that we see in our clinical practice. 1 attack every week, and 1 attack is disabling for 3 days. Just count the number of the days that you have. 12 days out of 30 days are miserable. So we want to reduce that misery for you, and that is where this Ntcgrp comes into play. Boom, your 12 becomes 6, 6 becomes 3, and that is a big change in the quality of life. Now, each of these attack, otherwise, what you would just be doing is popping either a painkiller, and a lot of people are just posting that questions that I take paracetamol or I take diclofenac. Now, that is, again, I'm re-stressing the fact we are not treating migraine, we are only treating headache, which is very, very important to understand. Marwa, I think this is important, and I want you to translate in Arabic, please.
الهدف من العلاج إنه نحن نتجنب النوبات الشقيقة اللي تصير مع الشخص. على فرض إذا الشخص عانى من نوبة بالأسبوع، نوبة كل أسبوع، النوبة طلعت معه 3 أيام، تصفى إنه هو تحت حصار الألم لمدة أكثر من 12 يوم. فهي العلاجات لتعالج مشكلة الشقيقة، لتبعد النوبات، تصفي أقل، الصداع يكون خفيف، تقدر تكمل حياتك اليومية وهي لو كانت موجودة تكون كثير بسيطة ما تقيدك.
Yes.
Yes.
Also, I will like to add, Dr. Magid, that the CGRP, this is a very important thing. What is NT-CGRP? We discussed that CGRP is, let's call it the bad guy in the story. This is the guy who is inciting the inflammation or iltihab inside the brain, causing all the chemicals for pain to be released each and every time. It is the one which is hitting on, let's say, it's like a little marble and it's hitting on to the receptor, and then cascade of bad things start happening. What we are trying to do is we are trying to block this receptor so that this marble like thing, which is CGRP, is not hitting it to start the whole process. So these are injectable therapies. It's like a little subcutaneous pen. Subcu is nothing but you give it in the skin, so you can give it on your thigh, you can give it on the outer arm. It's literally like a pen, and that is the reason why they are called pen. You can just, it's like auto injector, you just push it, press it, and the injection is delivered. Very, very safe. So that is, I think, answering a lot of people's what is NT-CGRP.
Exactly, Dr. Sweta. Thank you for your comments. I agree with you 100% that our goal as a neurologist and headache specialist is to prevent the migraine from coming. We want you free of headaches during this new era of preventive treatments. This is our main goal, that to prevent the attacks from coming and avoid you from using the medications and ER visits and etc. And I want just to comment also, as Dr. Sweta said, that calculate your headache days per month. Put your headaches in a migraine diary. Some of the patients, they have severe. Some of the patients, they have moderate attacks of migraine. So every headache, it means a lot for us as a neurologist in managing your headache. And it not necessarily, yes, 3 attacks or more, it will indicate a preventive treatment. But some of the patients, they have, for example, and I think Dr. Sweta, she is agree with me, they have only 1 attack, but they told doctor, I have this 1 attack lasting for a lot of, I have 1 week durations headache, and some of them, they have 14 days headache. So it's not, it's the days of headache. How much per 30 days you have headache? Okay, Dr. Sweta. So the question is repeated twice. What is the difference between the temporal arteritis and migraine in acute phase?
Temporal arteritis is a very unique disease that has no relation to migraine. It is where your temporal artery is swollen. There is a high ESR, one of the component in the blood, which is high, and it has the treatment very different from migraine. It is very different. You give steroids for that, and migraine is essentially no relation to temporal arteritis. So if you do have one, you have to go a completely different path. You have to prove it and take your steroids. That is the treatment or cure for temporal arteritis. Okay.
If you can allow me to answer these questions, we have repeated questions also regarding the rules of ergotamine and beta blocker. As Dr. Sweta said, now actually the ergotamine is an old-fashioned treatment. We not use it anymore, as it's carry a lot of risk, especially it causing the vasoconstrictions. So we not recommend to use the ergotamine now in the new era of migraine. The beta blocker, yes, it's helpful. It's good medications. But now, as Dr. Sweta said, now we are in a new era of migraine. We as a neurologist, we are happy for the availability of the new anti-CGRP treatments, beta blocker. If we compare it, efficacy of the anti-CGRP and the beta blockers, usually the efficacy of this new selective, it's a selective medications, it's preventing the migraine from coming with 0 side effects. So we prefer to use these new anti-CGRP other than the beta blockers. Okay, Dr. Sweta, one of patients, she said that I think this is how we differentiate between the migraine and other type of headaches. She said that all of a sudden she had in a few seconds headaches that explosive her head, okay, and this lasting just for a second. So do you want to comment on this?
Sure. So if you have short lasting explosive ice jabs like a headache, it is not migraine. Okay. There are a lot of other types of headaches which are suna, it's all complicated terminologies, but ice pick headaches and all, this is not migraine. Migraine headache slowly builds up. It's half-sided, often half alternating between right and left side. Light is a problem, sound is a problem, you can throw up, and you can be very, any sort of physical activity can provoke this type of headache. Generally, it is hours, it is not in seconds. So this is what you have to differentiate your headache to be. So if it is hours and all these features, bang on, that's migraine. And somebody has nicely commented that, is it important to have the diagnosis? Yes, it is important to have the label and not be afraid by it, because as I said, so many people are suffering from it. And because if you will know that this is migraine, correct method and correct approach can be taken to prevent it. So this is a sincere urge to all those people who are sitting on the fence, who have never got your headaches evaluated. My first request is speak to any of the neurologists, speak to us, and get it sorted. Get the label. It's not going to be, I bet, not going to be that bad as a label as any of those things like cancer. So just get your head straight and get a label right. Do you agree, Dr. Magid?
Yes, 100%. 100%. But there is another questions. It's repeated. There are a lot of them. They ask about the relations between the migraine and the menstruations and menstrual cycle. Does it occur before, during, and after?
Yes, menstrual migraine is a very big sort of a chunk of migraines that we see. Now, hormones, the estrogen and progesterone sort of play a very important role in the migraine headache precipitation. So when the estrogen comes down or progesterone goes up, the level differs and you can have headaches. So you can also have it post-menopause also, or perimenopausal, when you're just entering the menopause or stopping off the menstrual cycles. Now, menstrual migraines can be starting 2 to 3 days before the cycle and sometimes overshooting up to 2 to 3 days following the cycle. So it can be always repeatedly, recurringly happening in that cycle. Now, how do we treat it? Yes, we need to first understand that it's a menstrual migraine. Sometimes hormonal therapies help. While if the hormonal therapies also fail, Ntcgrp is also one of the injections which can be offered for the cure of migraine. The acute medication, which means when you have the headache, still remains the same. You can either take one of your NSAIDs or one of the triptans. But yes, hormone therapy becomes the pivotal role in any person suffering with menstrual migraine. And mind well, it can be as disabling as any other migraine as well. I'm also seeing a question, can excessive sleeping cause migraine? Yes, for some people, excessive sleeping also has been shown to cause migraine. I have had few patients who just oversleep during the weekend and then start getting an attack. So it can happen.
Nice that some of the audience, she asked or he asked whether the over happiness also aggravated migraine.
Yes, any emotion, any excess or under emotion, feeling depressed or too much work, too much stress. Now, it is very important to know that this is not the reason, okay? This is not the real reason why you have migraine. It is one of the factors which is precipitating it. And all you need to do is to work on them.
There is one also I want to comment, is not overeating also. As Dr. Sweta mentions in the first slide that yes, there is specific foods. If you eat it in excess amount, yes, it will, like chocolates. We have a patient with spicy foods. For example, I have patients before, or I think today, the triggers of her migraine is ginger. She tried it, okay, and so exactly after that she developed. So yes, if you eat a specific, you need to ask your doctor, and your doctor will explain to you which type of food that you need to avoid. Okay, Dr. Sweta, I think we have 5 minutes. We have here one audience. She is physiotherapist. She is complaining from physiotherapist. She is complaining from migraine after load of work. And I think you, as a physiotherapist, you should see by neurologist come and just go to your neurologist in your hospital, and he will help you regarding that. So one of the guests also asking about the treatments, acute treatments of migraine in ER, acute treatments of migraine in ER, in a specific patient's profile, like those having peptic ulcer, hypertension.
Yes,
diabetes.
so this is important. And if you are going to, let's say, PEP, then obviously any of this injection NSAIDs or diclofenac or this can be hurting your ulcer. So that is very important. But dexamethasone in my practice, I think that has been the savior once you go to the ER. We've been giving 4 milligrams or 8 milligrams of steroid, a cortisone, and that helps. However, again, for peptic ulcer, it's a no-no. So you have to talk about all your existing conditions before in the emergency room, and injection can be given. I don't have injectable Sumatriptan available in my place. I don't know, Dr. Magid, do you have that? So I'm in Ras Al Khaimah.
Which one?
Injectable Sumatriptan, the triptan, one of the triptan.
Yes, actually I ordered it.
Yes.
We have sub-Q injection, 6 milligram. Sumatriptan, and usually we use it up to 12 milligram per attacks or per day. Actually, yes, it's very effective. So we have the nasal spray also in our hospital.
Yes, perfect. So you can use a nasal spray or an injection of a triptan instead of taking one of these injectable diclofenacs or injectable paracetamol. So because as I told earlier, this is specific to migraine. You can't just pop in anything if you have knee pain or elbow pain. This is only treating your acute. Acute means your real headache during the attack. So it's important. Somebody also asks, can working long hours over laptop and phones and all that can cause migraine attacks? Yes, the screens have caused, the flicker frequency of the screen can induce migrainous attacks, especially in the young children. Now, mind well, we see quite a lot of young children suffering from migraine. So don't have this thing that children don't suffer from migraine. I would advise to use blue filters. So for example, if you see a blue shade around my glasses, it's because of the blue light filter. You need to have blue light filter. There is also a rule of 20-20-20. So once you have focused 20 minutes on your screen, look 20 feet far for 20 seconds. All you're doing is you're relaxing your muscles. So all these little tips and tricks are very important. And again, if you have to use the screen, for example, you're a banker, you can't help it, all that you have done, then obviously appropriate prophylactic or preventive therapy has to be ordered for you. And you can speak to your neurologist for that.
Exactly. So and now I think we cover, I have here, no, they ask about if there is a season affects the patients with headache, seasonal effects on headaches.
So if you have a headache pattern recurring every season, so for example, I said every winter, January or December, or every summer, June or July, you are having this rhythmic or a calendar pattern. And if it's again half-sided, behind the eye, it's causing the nose to be blocked, the eye to be teared, then this is what is called as cluster headache. And this can also be treated with one of the Ntcgrp. So it's important to, if you have one, please during that attack or before that attack, go and meet your doctor, because this can be prevented. If you anticipate in the next season, you can do some things to prevent it from coming. There are also some tablets which you can use. There are a lot of agents which you can give to prevent it from coming. So yes, definitely. It's possible.
Exactly. Seasonal headache is not a migraine. It's a cluster headache. And it can be used also by the same treatment that we use it for migraine. So any correlation between the hemophilia and or does the migraine affect on hemophilia disease?
Sorry, which disease?
Hemophilia.
Hemophilia. No, there is no direct correlation between hemophilia and migraine. But as I said, migraine itself is so prevalent that you will start seeing some accidental correlations with pretty much everything because of the sheer prevalence. 1/7 of the world. Wow, that's a very big number of people suffering from migraine.
Exactly. So here there is an important question, I think, from MS patients. She asked if there is MS medication like interferon beta 1A trigger the migraine. It's a nice question.
I have not come across interferons triggering the migraine, quite frankly, but I have very few patients who are on interferons, so I might not be the right person to ask that. But in any case, yes, there are some agents which can very much trigger the migraine attacks. I am seeing a lot of migraine attacks with the vaccines, which is also commonly happening. So yes, if you are one of those where it's getting triggered, go back to your doctor. There are so many MS medications available. I'm sure you will be able to switch quite easily and happily.
Yes, I agree with Dr. Sweta that also in my practice, I don't see a specific correlation between the interferon beta and the migraine itself. But we know that the interferon, it can cause a flu-like symptoms overall, but it's not a clear triggers for the migraine. I think still we have 5 minutes. I have a lot of answers, so they are the audience start interact with us. So I see if Dr. Sweta allow me, Dr. Sweta, she answered a lot of questions actually that mentions here in front of me. There is one question that can migraine induce seizure?
Okay, so this is a very important question. Thank you for bringing this out. Thank you, the participant who asked that. Now, there is something called migralepsy. Now, epilepsy or fits, which means seizures, or SARA, okay, and migraine, which is, we just talked about it, shakeka. Now, what happens is both of them have a common genetic predisposition. So it's the same channel which is causing the problem with migraine and the same channel which is causing the problem with seizure. So if you do have one, it is not just that there are two diseases happening. It's essentially from the same gene, both the effects are happening. If you do have one, the good thing would be that the tablet which we can use for seizure will also be helping us to treat the migraine. Generally, that is our practice. We use something called Depakin, but it all again depends on the individual person and evaluation of the person. And again, I'm not giving any therapeutic advice here, but this is just the general consensus that we are discussing.
Thank you, Dr. Sweta. I have here yes, Ntcgrp is a calcitonin gene-related peptide. Yes, it's this is the abbreviations. They ask about the caffeine, whether decrease or increase the migraine. Yes, I think we answered this question. Dr.
It's both ways. It's very interesting. For some people, the caffeine can be actually relieving, but largely most people, if you overshoot a certain dose of caffeine, it will trigger. So a lot of coffee, Arabic coffee is a big no-no, particularly Turkish coffees with very heavy amount of caffeines. That is a no. I have also a question, Dr. Magid, saying that how will you know if it's a migraine or just eye vision problem? See, we discussed that in the beginning. If there is an aura, you might see some flickering lights. You might see some shades. You might see some halos. You might see some breaks. You might suddenly see some stars, some geometric patterns. Now, this should go away and give into a headache. If this remains static, if this progresses, if this worsens, the next day you are not better off, it doesn't go away, that means it's an eye problem. Or sometimes it can also be a stroke which means a clot in the brain or clot in the eye which is causing it. So anytime if this remains, please go to your doctor and get it evaluated. So a lot of people are saying that bilingual presentation is nice and very informative. So thank you for that. Thank you, Marwa, for wonderful translation.
Yes, actually, I want to add for your comment, Dr. Sweta, yes, the aura that Dr. Sweta mentions about, actually, before 2 days, ophthalmologist, he referred one case to me. The patient is complaining from only aura. So he sent the patients to me, and finally we diagnosed it, which is it's good to share it here, that which is rare, that aura without headache. But this aura, the only neurologist, he can differentiate which aura is the migraine aura and which other visual problem is related to ophthalmology. And this patient, Dr. Sweta, she came after that, developed a migraine. So she remained with visual aura for a good period of time. Then when she came to me, she informed me, now I have the migraine, that the aura followed by migraine, which is very important.
Yes, yes, yes. And we do see this quite often. So my suggestion here to all the participants is, if you have one of these, there's no reason to be panicked, particularly if you are one of the young people that we just discussed, 25 to 50. You don't have to be too much panicked. But yes, the type of the aura, what you are seeing, how you are seeing, once you talk to your doctor and particularly a neurologist, it can be just a very quick game to understand that, yes, it is migraine, indeed migraine.
Exactly. We have here, I think it's an important point to clarify. He asked whether the migraine, all of the time it's unilateral or it can be bilateral.
Yes, this is very important. All the time, if it's side locked, that can never be a migraine. You need to go and get your scan done. It generally switches sides. Most of the times it alternates between right or left. So a very strict side locked headache, go and get your scan. This is one of the times when your neurologist would say, hey, you need a scan. So very interesting questions, Dr. Magid. Following the thing about migraine patients with aura, can it predispose to CVA? So thank you for bringing this out. Again, if we go back to the basics of migraine, there is a wave of depression. Depression means the blood is slowly stopping to flow in the brain, which is the reason for aura, followed by sudden gush of the blood, which is the reason for the headache. Now, if this flow of the blood is persistently down and it just does not convert into regaining the blood flow, it can convert into CVA. CVA is nothing but a cerebrovascular accident, or also called as jalta. Yes, it can happen, but it's very rare. It's extremely rare. And there are many, many other types of migraines which we did not discuss. There is also something called hemiplegic migraine, which means the person can develop jalta-like symptoms. So Marwa, I want you to translate these couple of points. And also the patient can develop ophthalmologic migraine, basilar migraine. All these are big buzzwords, but essentially what they mean is that you can have multiple symptoms along with your migraine attacks. And this is very important, to go to a neurologist and get it sorted. Really, if we look at the migraine, it's really big and huge. And all these are the types. Vertigo, or also called as what you call in Arabic, that is one of the, also the aura or the presenting features in a vestibular migraine. So Marwa, just translate that there could be these 3 or 4 types of migraine and one has to be aware about it.
الأهم إنه نحن نميز الفرق بين إنه هاي الآلام أو الأعراض اللي بنعاني منها هي أعراض شقيقة أو أعراض مشاكل ثانية، مثل ما قالت الدكتورة مشاكل كانت تكون جلطات أو تدفق بالشرايين بجانب الرأس. كيف اللي ممكن يميز؟ طبيبك بلحظة ممكن يقدر يميزها، هل هي أعراض تابعة من العيون، أو هي تابعة من تدفق في الشريان، أو هي تابعة من جلطات موجودة، أو هي أعراض شقيقة عادية. فالأعراض أو التشخيص اللي بتحكي لها الدكتورة بتفاصيله بتقدر تقيمها وبتقول لك لا، هلا الوقت المناسب إنك تعمل فيها أشعة الرنين لنميز، لنعرف هل هي بالفعل في كتلة أو في تجلطات موجودة، أو هي مشاكل الصداع مثل ما قلت الشقيقة بتكون عن طريق الآلام، بتكون منتقلة مثلا اتجاه اليمين أو اتجاه اليسار، ما بتتركز باتجاه واحد فقط.
Thank you.
Thank you, Marwa.
Thank you, Doc.
Actually, we need a further sessions to answer all of the questions. It's very interesting discussions. We almost finished now, 9:30. Dr. Sweta, thank you for your presentations. Thank you for your really beneficial information. I hope that Dr. Sweta and me answer some of your questions regarding migraine. Please don't hesitate to come to a neurologist. This is a message from my side that any patients with headache, don't ignore it, because we see a lot of patients came to us in advanced stage. So the proper doctor who diagnose and manage you, it's the neurologist and especially headache specialist. So don't hesitate to come to your doctor to seek advice if you are complaining from any type of headache. Thank you, Novartis. Thank you, Marwa. Thank you, Dr. Sweta, for this presentation. If you want to say anything.
No, thank you to all lovely participants. So without you, we cannot be here. And let's hope and pray that we curb the migraine, at least control it to the best of our possibility. My humble wishes to all of you. Thank you again, everybody. Good night.
Thank you.
Thank you. Good night.